Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically at any time using the Q&A pod located to the left-hand side of your webinar platform. You may also download a copy of today's slides using the Files pod located directly below the slide presentation. It is now my pleasure to introduce today's first presenter, Kevin Alvarez.
Good afternoon. As our announcer said, my name is Kevin Alvarez. I'm the Director of Community Health and Wellness at WellSpan Health in South Central Pennsylvania. Thank you for joining us today for the American Hospital Association's webinar, Health Behaviors and the Role of Hospitals. This webinar is part of AHA's efforts to advance health in America. The American Hospital Association, Health Research and Education Trust, and Association for Community Health Improvement are launching a series of resources, including guides and webinars on how hospitals can address various social determinants of health. This webinar will focus on what hospitals and health systems can do to decrease risky behaviors and encourage engagement in safer, healthier behaviors in the communities they serve. Hospitals featured in today's webinar are also featured as case studies in an upcoming guide also titled Health Behaviors and the Role of Hospitals. Before I turn over the program to our presenters, I'd like to explain how we will handle questions and answers today. At any time during the presentations, you may submit a question online by typing it in the Q&A box on your screen, specifying to whom the question is directed, and clicking Submit Question. When the formal presentations are completed, we will be taking questions from the Q&A box and posing them to our presenters. You will also be able to download today's presentation slides from the Today's Resources box on your screen. An archive of today's webinar will be available on the AHA website, aha.org, and at healthycommunities.org in approximately 1 week. Again, those will be available on aha.org and healthycommunities.org in approximately 1 week. With that, let me introduce our presenters. Jill Ward, Director of Community Health for Mount Ascutney Hospital and Health Center, Patricia Mitchell, Community Outreach Coordinator at Tanner Health System, and also from Tanner Health System, Phyllis Head, Community Outreach Coordinator. We'll start off with Jill. So Jill, you can take it away. Thank you.
Thank you, Kevin. It's a pleasure to be with you today and to talk about health behaviors. Admittedly, one of the most difficult things to change and to promote in promoting wellness. Today we're going to talk about, I'm going to share with you the goals and objectives of our community health program, stress that the techniques and the programs that we use are research-based and best practice approaches, and then be available to you now and at a later date as needed to share information that we have and to help you and work with you as you are on your journey to promote health. Our goals are taken really and based off Healthy People 2020, and I liken these goals to achieving world peace, because we're really trying to work to attain high quality, longer lives, to promote health equity, to create social and physical environments that promote good health for everyone in our communities, and to promote healthy behaviors, which is the subject of our discussion today. We're evolving as a community to create an accountable community for health, and really a medical neighborhood that maximizes this work with our partners. So you're going to hear a lot about that as we talk today. The first area that I'm going to talk about is that of teen drug use, alcohol use, and tobacco prevention. And in every section that we'll address, what I want to underline or underscore is the fact that we're adopting a best practice approach. So we really use experts such as the CDC and other partners working with our health departments in this effort. We do all of our work in collaboration. Nothing is done in isolation, and through it we've developed a strong group of networks within our community to accomplish this work. So you'll see listed on this slide the different partnerships that we've created, all with the effort to be able to work together and maximizing the resource of our community partners. We take every opportunity that we can to build capacity, both as a hospital and within our work in community health, but also with our partners. The commitment we make to each of the programs is to evaluate the work, and so that we can understand the impact of that work. In working with prevention for substance use, teen drug, alcohol, and tobacco use, we've done a series of things that you'll see listed on this slide. I think one of the things that's interesting is to talk about decreasing access. We know from our youth risk behavior surveys that access is primarily through friends and known people such as relatives and at friends' house. So what we've done is done a public campaign and worked with our police departments to develop drug drop boxes so that anyone, anytime can bring medications that are completed in their therapy, and so that they get out of the house. I think, working with older people, they tend to keep medications around for that time, well, I might need them at some point. And we're trying to discourage that and let people know that there's a safe place to bring the meds, and that they're doing a good thing by getting them and keeping them out of the hands of teens. We do a series of PSAs widely throughout our region to advertise what is safe use, talk about safe storage and disposal. We serve as a resource for the towns in our community. One of the more successful strategies of late has been working with the environmental approach of reducing tobacco litter. This appeals to a broad spectrum of folks in the community. Just as an example, we're working with the Wild Women of Windsor. And that group of really invested and enthusiastic ladies are helping us purchase cigarette boxes that we can put up through the town with actually messages around cessation. And it's something that can give the message, and the town views as a real partner. We're a real partner in improving the environment in our communities. We've done a lot of education recently on sales of flavored tobacco and on vaping. And in Vermont, which is where Mount Ascutney Hospital and Health Center is, we are working, because we've recently the legislature has recently passed marijuana legalization. We're working with towns and communities about local ordinances that can be voted on to make sure that any drug paraphernalia or retail outlets are not near schools, near libraries, and that towns can take control of their environment and vision what their environment should look like. We've done in the last 3 years a significant amount of work with our regional planning commissions. We're helping establish town health and wellness committees and policy guides for the town plans. Our hope is to have a toolkit which we're working on right now, that can give a template to each of the towns for their health chapter in their town plan. There are a myriad of programs that we work on with the schools and in the community to raise awareness about legal penalties for providing alcohol to minors. And we particularly work in that area around the graduation and prom season. Schools are one of our strongest partners in this work. The next area that I'd like to share with you is our work with the health department on the 3-4-50 campaign. 3-4-50 relates to the three behaviors of lack of physical activity, poor nutrition, and alcohol use that lead to 4 diseases: cancer, heart disease and stroke, type 2 diabetes, and lung disease, that are responsible for more than 50% of the deaths in Vermont. And we have worked with our community to provide education, to engage the community, and to celebrate the work that people are doing in each of the areas of the 3 behaviors. What we had done in the first year of this campaign was to develop presentations, and we did outreach specifically in our communities to each of the town select boards, to our schools, to daycares, to health and human service agencies, and to businesses. And in each of these presentations, what we would do was we would provide a resource list of opportunities with websites, which again I'd be happy to share with anyone that's interested, to make available to people to encourage their journey and to challenge them to implement strategies that will improve their diet, that will promote cessation or help them to not take up that cigarette, to defer the, smoking, and to exercise. What we did was, with each of the presentations, we had a series of postcards, and we challenged each of the presenters, each of the participants at the presentations to be a champion themselves. And so they would take a postcard, and on those postcards, I'm going to go back to that. This is a picture of the tip cards that I spoke about earlier. These are the postcards. And on the postcards, it provides education about 3-4-50, so it can inspire and give confidence to the people that are going and doing the outreach to their neighbors and friends and their coworkers. And then it gives a place for their coworkers and neighbors and friends to brag about what they're doing for healthy eating, exercise, and tobacco use. Those are sent to me, and we put those on our local Windsor On Air, our public access TV, so that we can celebrate what the community is doing and then continue to share the message. Outcomes, as I said previously, are very important to us. So what we did was pre-establish what our goals were for this project around smoking, around fruit and vegetable intake, exercising, use of the ED, and A1Cs through our EMR at the hospital. So we are pre-established goals, and we're working diligently to get the word out. In the first year, it was primarily presentations to those sectors of the community that I highlighted. Year 2, we're trying to shake it up a little bit, and we're running contests through the towns for people to pick their favorite vegetable, identify their favorite form of exercise, and pledging not to smoke. Again, with change behaviors, it's more successful if you engage people, if they have a stock in the game, and in this case, we're talking about celery stalks as well as broccoli and green beans. And you'll be pleased to know that broccoli is currently the Windsor winner. We will in the spring be spreading seeds throughout the communities, again to highlight, reinforce the message, and the idea is to create new norms and send the message of these health behaviors. The third program that I'm presenting today is around our family wellness program. The purpose of our family wellness program is to improve the lives of those we serve by coaching the well to stay well, by helping those at risk to reach towards being well, and by helping those in treatment to reach towards wellness. We set this up initially as a community program, and then soon found that the most effective technique was to embed the service in our pediatric program. So we now have a wellness coach that's embedded in our pediatric program, teaching parents and working with kids on the wellness domains. This work is based on the work of Dr. Hujek, who is working through the University of Vermont in the family-based health promotion, wellness, and prevention program. You'll see an article in the slides to give you more background of this program, but he is a pioneer and has provided training to our wellness coaches in this work. You'll see the wellness domains listed on the slide. Particular importance is placed on parenting, but we start with questions and concerns that the families have, and then branch from there. A lot of concerns on sleep hygiene and creative work, which has been studied to really this to be an antidote to the ACEs information that we have all become familiar with in the recent years. We concentrate on emotional and behavioral health and find that and believe that that's the foundation of all health. And we stress the family unit. The message to families is that you can grow your brain, that there's evidence-based strategies for emotional and behavioral well-being, and that we can change our brains through certain practices. We do an assessment which leads to celebrating the strengths that are within families, and then come up with practical strategies for families to help them face their challenges. The program is structured so that the wellness and behavioral coach starts with an introduction at 15 months and then works in tandem with the pediatrician at 18 months with follow-up at the regular well child visits that you can see here. We also work with clients in understanding behavior, disruptive behavior disorder, ADHD, and we help develop strategies and programs to work with their children. We also have access to an MSW who works with those that are at risk, and also refer to treatment as indicated. We use our friend Dr. Spock. Actually, I have to say I was initially confused about Dr. Benjamin Spock and the Spock you see on your screen, but both are good resources in our process. We have adopted the model of live well and prosper, and that's the work that we're doing to promote family wellness in our community. I see that I'm a little ahead of my time. I was rushing through to make sure that I didn't impinge on the Tanner presentation. So I'm going to stop here, and we'll have more time for questions. I want to introduce Patricia Mitchell and Phyllis Heath, who now share the Tanner Health System strategies to encourage healthy behavior. Thank you for your attention and your time.
Okay, well, thank you, Jill. Hello, this is Patricia Mitchell, and I will be starting off for presenting with Tanner Health System. And as you can see, our presentation is on community-based approaches to improving health in rural populations. So as we take a look, let's talk a little bit about Tanner Health System. Tanner Health System consists of 5 hospitals and 30 medical groups that serve 9 counties, in West Georgia and East Alabama. We actually just opened our 5th hospital in the fall of 2017, and this was in Wedowee, Alabama. And as you look over the slide, you can see that we actually have a little over 300 physicians and 3,200 employees working for Tanner Health System. So looking at our milestones, Tanner had visionary board members that really wanted to do more for our community, and they started our first community health division. And as you can see from our slide here, in the span of 6 years, Get Healthy, Live Well has completed 2 community health needs assessments, been awarded the Community Transformation Grant and the Partnership in Community Health Grant. With that, we were able to get quite a bit done. We were also awarded the NOVA Award from the American Hospital Association in 2016 for improved community health status and collaborative joint efforts with other community leaders and associations and organizations. So looking at our key issues, as I stated earlier, we completed 2 community health needs assessments. And when they were completed and we looked at them, you can see what our priority areas of focus were. So when we look at these, we have access to care, chronic disease prevention and management, behavioral health, and then health education and literacy. So looking at how we compare, you can see this is where we stand with the latest data of 2017. And it just gives us a snapshot of some of the key indicators from our 3 primary service areas. And as you look on here, you'll see that that is Carroll County, Carrollton, and Heard County. And you can see how we can compare to the state of Georgia and then, of course, to the United States. So the next thing I wanted to kind of talk about is our coalition. And this is actually a picture of our current coalition plan. And we have grown over the 6 years. We have grown, and we now have 28 task forces with over 500 community members to address the needs of that community health needs assessment. So building communities. As you can see, involving the community has been very important to get the work done. I'm just going to touch on a few of these, but as you look down, we have 17 faith-based partners that have been very important to our work. We have 49 physicians referring to our evidence-based classes. And we have established a preceptorship with the University of West Georgia Nursing Department that has actually been very helpful to get the work done that we needed done. Right now, we currently have 70 students assisting us for this semester, which is wonderful because spring can be a busy time of year. So our targeted approach, when we look at this, one of the key issues from our community health needs assessment was chronic disease prevention and management, and that was with an emphasis on obesity, diabetes, heart disease, and cancer. We tailored our plan around that, and these are the areas that we are addressing. So you can see that is physical activity, nutrition, chronic disease, and living tobacco-free. So now what I'm going to do is I'm going to start touching on to a couple of programs, and the first one I actually want to mention is our Move It Mondays program. And this is kind of to address the physical activity. So we have partnered with West Georgia Track Club. It's a local running club in our area to provide a couch to 5K program to the community. We actually offer this program twice a year. We do it in the fall, we do it in the spring. It is a free program. Everybody is welcome to come, and we are actually currently in our 6th session. Way this program kind of works, just real briefly, is the track club members partner up with different participants in the group, and they help them to improve either their distance and or time. The next program that I want to touch on real quickly is our kids exhibit, because we know that our children are not as healthy as we were when we were young. So this is a program that we take into the schools. We have 10 stations that are fun, they're interactive, and they provide short lessons that focus on nutrition, physical activity, and the dangers of tobacco. And as you can see in the pictures, it looks like we are keeping the kids' attention, which sometimes can be difficult. So at this point, I would like to turn the rest of our presentation over to Phyllis.
Thank you, Patricia. I'm going to zip through these next slides as quickly as possible, so stick with me. After receiving the Community Transformation Grant in 2013, one of our focus areas was the built design, and we were lucky enough to have Mark Fenton come speak to the community at a health summit about building or rebuilding a community from the ground up to promote health and wellness. Mark got the community really excited about the idea that if you change your environment to promote health and then back it up with policies that continue to support those healthy changes, it makes for a bigger and more lasting impact than, say, a health fair or a 10K or a fun run or any other kind of health-related event. And so Tanner spent a great deal of time and effort partnering with several of the local groups that supported those ideas. One of these groups was the Friends of the Carrollton Greenbelt. This local group was in the middle of a project to create a loop trail designed for pedestrian and bicycle use. The trail is now the largest paved loop trail in the state of Georgia. This trail runs through local school systems, the University of West Georgia, several of our large business campuses, as well as several of our low-income neighborhoods and elderly communities. So Tanner helped in promoting that trail. We provided signage throughout the community at all the trailheads, and we helped to start a citywide bike share that has been incredibly successful and also encouraged many other programs that use the Greenbelt regularly. We partnered with Carrollton City and provided training for them around complete streets policies and implementation. They continue to work on providing the community with streets that are designed not only with cars in mind, but with pedestrian and bicycle safety in mind. So as you can see, we did a great deal of work in support of policy, systems, and environmental changes in our community. And now I'm going to go back to some of the programming we've implemented in the community that Patricia was talking about. Again, I'll touch on these quickly because I'm sure most of you are familiar with a lot of these classes. Cooking Matters. We held over 25 different classes with our local universities and colleges, in local churches, working in partnership with low-income neighborhoods and in our local housing authorities. And now we are currently focusing our efforts in teaching parents and caregivers of children from 0 to 5 years old in healthy and inexpensive food preparation. Kids in the kitchen. This one is a pretty simple idea. We designed mobile kitchens to use throughout our school systems to teach the kids about healthy eating. The schools come up with a curriculum, and then they apply to us for a grant to receive the carts and use them throughout the school year. We also have some of these at local libraries. We can use them in the community as well as the school system. Youth tobacco education. We came up with the Don't Be a Bonehead campaign. We went out and talked to students and kids and said, what would appeal to you in anti-tobacco messaging? And this is what we came up with. We take every opportunity that we can to show the kids what smoking can do to their health and encourage them to not to start using tobacco. Okay, next. I want to focus on our community clinical linkages with our evidence-based classes. Simple enough. Patients come in, nurses assess them for readiness and flag them for classes that we teach that might be beneficial, and then the doctor talks to them about the class and makes a referral. Then Get Healthy Live Well calls them, enrolls the patient in a class, and then reports back to the provider after they finish the classes with an update. We've just recently added all of our classes to the electronic record system used throughout our service area in an effort to make it as easy as possible for our care providers to get their patients to our classes. So our classes include the Fresh Start Tobacco Cessation Program, which was developed by the American Cancer Society. The Diabetes Prevention Program, which was developed by the CDC. And again, I'm sure y'all are familiar with a lot of these classes, so I'm just going to run through these quickly. Living Well with Chronic Disease and Living Well with Diabetes, CDSMP and DSMP, which were developed at Stanford University. Those are the classes that we're currently working with our doctors to provide education for the community. And then lastly, as part of the pitch grant that we received in 2014, we were asked to identify a priority population that we thought would benefit from intervention around chronic disease, nutrition, physical activity, and tobacco usage. Because we're right in the middle of the Bible Belt, we chose the African American churches in our community. We worked closely with 11 churches over a 3-year period and had wonderful results. So let's go over this. We worked, we had a big policy event where we worked with every church. They all came and sat around tables to sit down and come up with what they could do in their church to promote health. 100% of our churches adopted a tobacco-free policy. 100% of the churches adopted a water policy where at any event they always provided water as an alternative to soda or sweet tea. 90% of our churches integrated physical activity into their church activities. They might get up during the service, or they might get up off their chairs in choir practice and kind of run around the room. 82% of our churches implemented an evidence-based program and have partnered and have pastor congregation members trained as peer leaders for these programs. So we did a train the trainer scenario. We trained people in every church to be able to teach in their own congregation. And this works really well in the churches because the level of accountability is so strong. When you have to sit down in a class with your pastor, you want to do really well. See, next slide. Here are some of the results after 3 years. You can see that the percentage of church members with cholesterol in the healthy range vastly improved. The percentage of church members with hypertension, stage 1 or 2, you can see dropped. And lastly, let me get back up here. You can see health knowledge improvement. Everyone at the churches felt like after we had been working with them for 3 years and after they'd had the classes, that they were very knowledgeable about issues that before they had not felt quite so knowledgeable. So that was really big for us. So now we've expanded the faith-based wellness group to include all the churches in our area and are currently working with 17 churches who enjoy quarterly challenges around health issues. We do the resolution run on New Year's Day. We have a Hoops for Health basketball challenge throughout the community where the churches play each other. In the summertime, we do the Bible Quiz Bowl, and we challenge the church's knowledge of the scriptures. So we have a big quiz bowl. And then in the fall, we go to a football game and have a healthy tailgate cook-off challenge where all the churches get together and provide teams to show how you can cook healthy alternatives to your typical tailgate fare. And all the churches vie for temporary ownership of the Hallelujah Cup. They get really competitive, let me tell you. These churches really enjoy these challenges. And lastly, because I'm very proud to be part of Get Healthy, Live Well, I'll close with this slide showing the state, national, and international recognition that we've received for our work over the past 6 years. Thank you.
Thank you, everyone, for your time. Before we move on to our Q&A section, we would like to draw your attention to our webinar evaluation form, which should be popping up here in a moment. There you go. So please click on the link and you'll be taken to an online survey which will open in a separate tab on your web browser. We hope you'll take this opportunity to evaluate the program and help us understand what is working well and what was most beneficial to you. So it seems that we have ample time for questions, and a few questions came in today, so we are going to run through those, and I'm going to start with a question for Jill from Mount Ascutney. Jill, you had mentioned about the transition that's happening from tobacco use to marijuana use and the legalization of marijuana in the state of Vermont. The effect of that legalization of marijuana, does it have any challenges with Mount Ascutney's health goals as a health system? And also, what are the downside effects to that when it comes to the potential of driving under the influence now of marijuana, whereas when you were doing work in the tobacco arena, obviously tobacco use does not lead to a potential DUI.
So talking about your, answering your last question, I would say that we have gained information from looking at other states such as Colorado to understand the outcomes in their environment and use that prior to the legislation, actually for several years, to educate the legislators about the impact of driving under the influence with marijuana. This isn't, the same issues as tobacco. I think in tobacco and cars, it's the secondhand smoke. But and the legislation has just recently passed, and so it's too soon to tell what the impact is going to be. But as with alcohol, this is a tough issue, and it's one where we feel that we need to be in front to educate and not leave any of the generations out of this discussion, and talk about it as it relates to their health. There has not been any conflict with the medical care provided by the hospital to date. So I'm assuming that the question relates to medical marijuana. Again, there has not been any conflict or any concerns raised around this issue. Time will tell as we move forward. This is very new for us.
Excellent. Thank you, Jill. Another question that came in that can go for both Tanner and also Mount Ascutney is, are you adding classes into your electronic health record, and how have you been able to integrate the class and community initiatives into your respective health records?
Hi, this is Phyllis. Actually, we have just recently added our classes into our electronic records. We're doing this slowly, going practice by practice to integrate those so that we're not overwhelmed with requests for classes, so that we're trying to ease into it. But we're really at the very beginning of that process, so I don't know how much I can speak to how well it's working. So far, so good.
And this is Jill. We have not taken that step. Currently, what's happening with the EMR is primarily around screening for risk. Our classes are personal, and we find that the group dynamics are really important in the success and the outcomes. At this point, we don't have the technology that would allow us to implement the classes through the EMR.
Thank you, Jill.
You're welcome.
I'm going to switch a little bit here. We have some program-oriented questions, but I think that a lot of the questions are centered around 2 or 3 key areas. So for both health systems, how are you funding your outreach activities and your programming, and do you believe that funding is sustainable in the long term?
So this is Jill. I would say that our primary funding mechanism is through grants. We've become facile in applying for funding through state, federal, private foundations for our work. One of the issues in Vermont is with healthcare reform, and working with our ACO is an emphasis on prevention as part of the continuum of care. So my hope is that we will be able to capitalize and put substantial resources in that area of prevention and health promotion through resources from the ACO. They've adopted a best practice model, and we've adopted a best practice model that looks at the continuum of care from prevention through high-risk, chronic, and complex patients. So I do believe there's a commitment to continue that work. Recently, through the ACO, there was an investment with RISE Vermont, very similar to the work that we're doing with 3450. And with healthcare reform, the idea is that communities will be able to invest in programs that have shown to be effective. Our plan is to include prevention in that work.
Excellent. Thank you, Jill. Patricia or Phyllis, how have you supported the programs, or what kind of grant funding do you receive to support those programs and initiatives?
Well, we also primarily work with grant funding, but we create all our programming with an eye towards sustainability. So with our Train the Trainer scenarios in the faith-based area and really throughout the community, we teach our people to teach themselves. So those programs, we no longer have the grant funding that we had in the faith-based, but it has continued working very well because they are continuing those programming. So we do everything with an eye towards sustainability.
Excellent. So that brings me to the next question. Obviously, both of your organizations have a tremendous amount of initiatives that are happening in your communities, and those of us that work in the community health realm know we can't meet all of the needs out there, especially with the limited staffing resources we often have. So what does your staff makeup look like? How do you engage or bring new staff on? Not the onboarding process, but what skill sets or educational background are you looking for to help you staff appropriately to meet the community needs?
Okay, this is Patricia from Tanner. So our staff makeup is really, is Phyllis and myself as the community outreach coordinators. We also, of course, have a director. We also have some part-time help. We've actually brought in another staff member under the USDA food grant and another one for the Georgia 2 initiative. So as you can see, our staff is very small. That was why in one of the slides we really highlighted our community partners, our partnership with the University of West Georgia with the nursing students. We also have connections out there with the community and health wellness department, and we use those students. It gives them kind of actual work experience, and of course it helps us out. So community involvement is key for us.
And this is Jill. We have a very small staff too. Myself, we have 3 members of the Mount Ascutney Prevention Partnership. Their salaries are paid through multiple grants, and they're involved in a full range of programs in prevention. Our staffing does expand and contract related to the grants that we're able to get to meet specific goals and objectives. And those goals and objectives are based on primarily the community health needs assessment and the priorities for the community.
Thanks, Joe, because that was a great segue into my next question. And for both organizations, how are you evaluating and tracking your results, especially when it comes to community health needs assessments and the requirement that we evaluate the work that we're doing in the community and share that back as great work to both the IRS and our community partners?
So we have...
Oh, sorry, Jill.
Go ahead, Phyllis.
Okay, this is Patricia from Tanner, and so we use Georgia State Policy Center. They have helped us with our evaluation with many of our classes and the programs that we do. We, of course, with several of our programs, we do a pre-survey, we do a post-survey, then we take all that information, they evaluate it for us and, present it back to us.
And this is Jill. We, early in the 1990s, we had a partnership strategic plan where we used the community health needs assessment to develop our goals and objectives based on the health data available to us. And we have established objectives which we track through the Youth Risk Behavior Survey, the BRFSS, and other objective or validated tools that are collected by external agencies. Then with specific grants where we have the ability to design targeted evaluations for the outcomes of those programs. So we are committed to doing a longitudinal evaluation using the Youth Risk Behavior Survey and the BRFSS, but then also program-specific outcomes.
Excellent. Thank you. So a follow-up question is related to the needs assessment versus what is called an asset-based assessment. So many healthcare systems and hospitals are conducting their community health needs assessment, but have either of your organizations actually thought about doing an asset-based assessment?
Actually, yes. We've done that with the schools over the years. And they've implemented the asset development assessment, and then we've been able to utilize that. The other thing that is done in our Youth Risk Behavior Survey, they have several asset questions. One of them that immediately comes to mind is youth feel that they matter to the community, volunteerism, and we have sent, to build capacity in our communities, we have sent people for training on the asset system. So we're in the process of doing education with our partners and in the community about the power of assets and using a strength-based approach.
Excellent. Jill, how about Mount Ascutney? Are you using the asset-based management assessment? Excuse me.
That was Jill. I'm
sorry.
That's okay.
Phyllis or Patricia?
Hi, this is Phyllis. Actually, we continue to assess the community for. I don't really know how to answer that. I'm not really sure. We haven't gone out and done an assessment survey like you're talking about, but we, on a continual basis, assess the community for resources. So.
Okay. Thank you. So one of the issues that's plaguing a lot of our communities across the nation is the opioid epidemic. So in your communities, have opioid issues become a challenge, and do you feel that your health systems are equipped to meet some of the evolving community needs like this one?
This is
Hi.
Jill. So this is Jill. The community health needs assessment has shown that alcohol, drug misuse, and heroin use is the #1 community concern. And so we've done a significant amount of work in this area. We've implemented in our emergency room and in our clinic what's called expert screening, brief intervention, and referral to treatment, so that we can identify in a systematic way early risk and refer to treatment. We've started, our providers have adopted the best practice rules from the Vermont Association of Medicine, the Medical Society, and we work with prevention in the programs that were highlighted at the beginning of my presentation. We've also developed a chronic pain consult team, which is a multidisciplinary team that addresses patients that are challenging in reducing and tapering protocols. And we work with the hub and spoke system for medication-assisted therapy. Through the Blueprint for Health, we've been able to hire an RN and a counselor for every 100 patients on medication-assisted therapy to address the social determinants of care, to be able to help with counseling and to provide support in their recovery process. Our pediatricians have started a clinic for the addicted moms of some of our patients, so that we do medication-assisted therapy. We have a therapeutic play group and a counseling group for those moms. We've done a lot with education of the providers and implementing protocols in the community, for the community, excuse me, and a significant amount of community education. We work with the state in the development of programs in our community, and so this has been an area where we've spent a significant amount of time for community health. I don't expect it to be, I expect it to be among the top 5 in our community health needs assessment that we're currently conducting. So we're in this program for the long haul.
Hi, this is Phyllis. from Tanner. We have Willowbrook, which is a behavioral health hospital in our service line, and we use we have a youth mental health initiative that does first aid training, opioid, dealing with both opioid use and suicide prevention. We are also currently training first responders in our service area to use Narcan and helping to procure monies to pay for that initiative. So we are addressing those issues, and we will continue to do so through our behavioral health hospital.
Thank you. This question originally started at near the top of the hour for Jill, but I think it's both appropriate for Mount Ascutney and Tanner. But as an integrator in our communities, a hospital and health system serving as an integrator to bring people together around community health issues, are there any downsides to that? For example, would a downside potentially be that other organizations don't want to get involved or they don't want to take ownership? So obviously you're bringing people together, but are there any downsides of being that integrator that Jill talked about in her presentation?
Well, go ahead, Jill.
I say that I don't see any downsides. I can tell you that before we did this, there were downsides. I remember my first experience as working in community health. I wrote a grant for a community school-based clinic, and I thought it was wonderful. And so I boldly shared it throughout the community, only to find out that there were placards on cars in the parking lot to stop the school-based clinic and to come to a meeting in town to take a stand against what was most likely a Planned Parenthood initiative. This was not at all what we had planned, and so I actually went to the meeting and addressed the folks, and out of that came an approach building in our community that that has resulted with significant trust and building of networks in our community through an infrastructure that I listed, that's allowed us to do work exponentially. We couldn't do this by ourselves. Just for 3450, I worked with our deemed mental health agency. We worked with our ACO. We worked with daycares, and we work with law enforcement. Significant community partners that only aid and augment and strengthen our work. I find their perspectives and their approach to be a real strength to the work.
Hi, this is Phyllis. I agree with Jill. There's there's no downside. As we've partnered with the community and we've encouraged everyone to take ownership of the issues that we deal with. So we're no longer the owner of all the problems as the hospital, and so it's really expanded our ability to address other issues. It's expanded our reach. We can delve into other things because we incorporate the entire community and everybody does their part. So it's made it much better for us.
Excellent. Thank you to our presenters, Jill Lord from Mount Ascutney Hospital and Health Center, Patricia Mitchell, and Phyllis Head from Tanner Health System. I know some additional people might have asked some questions, but we do have a time constraint, so I wish that we could have gotten to all of those, but we apologize that we were unable to. We will send any unanswered questions to our presenters, and hopefully they can respond to you regarding those. Again, thank you both Jill, Patricia, and Phyllis for sharing your expertise with us. Stay tuned. As you'll see on your screen, there will be an upcoming guide that I mentioned at the top of the hour entitled Social Determinants of Health, Health Behaviors and the Role of Hospitals. That will be coming soon. If you have not already done so, we hope to see you next week in hopefully sunny Atlanta, Georgia for the annual ACHI National Conference, which is March 14th through 16th. You can still register. There's still plenty of room and time for you to join us for that event in Atlanta next week. And lastly, to stay connected, and up to date on HRET's and ACHI's latest reports and webinars, please follow them on Twitter. You will be able to access the recording and presentation slides from today's webinar on AHA.org, that's the American Hospital Association's website, and also healthycommunities.org. That will be available in approximately 1 week. With that, again, I want to thank our presenters and all of you for joining us this afternoon. Have a great rest of your week and a great rest of your day. Thank you.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.